welcome you all to this segment which is titled The Veterans File. Now this was an addition to our academic sessions from last year onwards. That was from the session that was held in Kandy. The idea behind the new feature was to tap the clinical experience of senior physicians, very senior physicians among us who have years of experience in managing patients. So we thought that we had much to learn from them. So we introduced this segment called Veterans File. So yesterday, Professor Saman Guntilaka spoke to us on his experience. And today we have another senior physician, very senior physician, to talk to us. And may I invite my co-chair, Professor Namal Vijayasinghe, to introduce the speaker today.
Our speaker today is Professor K.H. Selleheva, who does not need any introduction to this audience. However, Professor Selleheva is one of the most senior practicing physicians currently in our country. His current position is professor in medicine at the Sir John Kotalawala Defence University. As you know, we have two parallel professorial units. So he's professor at Colombo East Teaching Hospital, part of Kotalawala Defence University. Before this, he had a long career at Health Ministry until he retired in 2008. He has served many parts of the country, and most of us have been taught by him as an undergraduate or a postgraduate, or at least as an examiner. He has examined us. So without much details in introduction, I will invite Professor K.H. Selleheva to talk to us. Over to you, sir.
Chairman, ladies and gentlemen, when Dr. Premali asked me a few weeks ago whether I could be a resource for this Veterans Forum, it suddenly dawned on me how old I have become. Anyway, the heart is still young, and I'm very thankful to Dr. Premali, as well as the President and the Council of the Sri Lankan College of Internal Medicine for having given me this opportunity to share with you all some of my experience in a career extending over 48 years, I think, knocking on the almost at the half a century mark. Thank you also, Namal, for your very kind words of introduction. Now, in this presentation, I shall take you through some patients who presented with acute abdominal pain, patients who passed black-colored urine, and some unusual complications of dengue infection, as well as some patients in coma. And all this will essentially be a revelation on the art of clinical medicine. Now, how relevant all this one might ponder, owing to the abundance of technology we now have at our disposal, with all its sophistication. You heard about that in the preceding seminar, and also the diversity and the depth of subspecialization. But despite all that, I still feel a general physician functioning as a clinician, and this I say without any reservations whatsoever, has a very important role in the rapid delivery of care, which is patient-based and not just disease-based. It has to be appropriate, decisive, and of a humane nature. Now, when we come across a patient with acute abdominal pain, we work with this mindset of whether we are dealing with a patient with acute abdomen, which is certainly a surgical emergency, or else it could be some other underlying cause which does not require such urgent surgical intervention, like a renal colic, cholelithiasis, or even pancreatitis. Now let me take you back to 1973, working as an intern medical officer at the Colombo South General Hospital, which is now called the Colombo South Teaching Hospital. And working with that mindset, I was clerking this middle-aged male who had vague upper abdominal pain and mild pyrexia. On examination, I found the abdomen to be quite soft without any tenderness or guarding or rigidity. And I knew the patient didn't have an acute abdomen, but the patient looked ill. Because he came with abdominal pain, I did X-ray of the abdomen, which was also normal. So at the end of all this, I had no clue, absolutely no clue as to what the diagnosis was, except I was quite confident, inexperienced as I was, still an intern, just a few months into my career, that the patient did not have an acute abdomen that needed an urgent laparotomy. But the patient looked ill, so which made a point not to ignore the patient. There was something seriously wrong, but I didn't know what it was. And there was no one to ask. Those days, it's just the consultant surgeon and the intern, that's all. There are no registrars, senior registrars or anything. So I did the next, at least the only available option to manage this patient conservatively, keeping the patient ill only with intravenous fluids, but made it a point to repeat the clinical status of the patient whenever I got the opportunity to do so, to see whether he was developing any new signs. The next day, the surgeon saw the patient and it will continue your conservative care. But I felt very uneasy as no definitive diagnosis was made. And I continued to review the patient clinically for new signs. Nothing appeared. Then suddenly, the next day, he complained of a severe right-sided chest pain, collapsed, went into shock. The physician was consulted, but all our attempts at resuscitating this patient failed and the patient died. So here was this middle-aged gentleman, 2 days in hospital, a fatal outcome without having made a diagnosis. Now I want to know, what did I miss? What was the cause of this patient's death? So the only way we could find this out was to do a pathological post-mortem. But those days, in surgical wards, they don't do pathological post-mortems. They're only interested in judicial post-mortems. And the nurses, as usual, came to me. Then the doctor death certificate with that book. I thought the best way to get a pathological post-mortem was to stay without giving the death certificate. I must have had some of these rebellion tendencies even as a junior puppy. Anyway, so with the surgeon's permission, we managed to do a pathological post-mortem, and it revealed an amoebic liver abscess on the superior surface of the liver, which had ruptured into the peritoneal cavity. Patient went into shock and caused death. Now, when I found that out, that the patient had died of a highly treatable condition like an amoebic liver abscess, I was simply devastated. I just couldn't bottle it, because even up to that time, just a few months into my career, but I had come across 2 or 3 patients with amoebic liver abscesses, which was very common in that era among toddy drinkers. But all those patients had these typical features of intercostal fullness and tenderness. We would do a chest X-ray, look for the elevated hemidiaphragm. Total and differential white count will show a polymorphonuclear leukocytosis. Those are the only 2 investigations that were done. Then we pick the point of maximum tenderness in the intercostal space, put in a needle in the ward itself, absolutely blind procedure, and the needle will hit the abscess like a heat-seeking missile. We aspirate the pus like the anchovy sauce. And when you see that color pus, we know your diagnosis is confirmed as an amoebic liver abscess. And then you start the patient on intramuscular hematine, discharge on chloroquine to prevent relapses. Now, this particular patient didn't have any of these typical clinical features of an amoebic liver abscess, that is the fullness and the tenderness of the intercostal space, because this abscess was in the superior surface of the liver. Despite all that, I couldn't sleep that night. Only one thing haunted me. I was thinking, if I had ordered a chest X-ray instead of the X-ray abdomen, that would have made a different story. Maybe that patient's life would have been saved. But the problem we had in that era is even X-rays were very, very sparse. 46 years later, 11 years after my retirement, working at the Neville Fernando Teaching Hospital in Malabar, which is now called the Colombo East Teaching Hospital. This middle-aged male, who had a febrile illness and vague abdominal pain and chest pain, had gone to several hospitals, seen many doctors, extensively investigated and treated, and he had felt better, but not fully cured. So he came to see me to find out what was really wrong with him. And I saw him. He looked quite well to me. He was seated beside me, and I looked at his face, felt his pulse, and I thought, this chap is perfectly normal. I was wondering why was he coming to consult me. But he was saying, insisting that he was not well. He was leaning forward, tapping the back of his chest, and told, I have pain here. And he also told he had a pain in the right shoulder. I told, raise your arm. And he raised the arm without any issue. There didn't seem to be anything wrong with his shoulder. But for whatever, I was about to write a placebo prescription and send him off, thinking that he was perfectly normal. But for whatever it was worth, I thought I'll examine him on the bed. And as expected, the abdomen was perfectly normal. Got him to sit up and lean forward. When I examined the back of the chest, there was an impairment of the percussion node in the right lung base. So taking these two factors into consideration, the right basal lung signs and the pain in the right shoulder, I suspected this patient to have a liver abscess in the subdiaphragmatic region. Now I got the patient admitted. He wants to know, why do you want to get admitted? He was all right. I told him, no, you had to get admitted because the bad experience I had as an intern was floating back into my mind. So got him admitted to the free ward, thanks to Dr. Neville, late Dr. Neville Fernando. Even though it's a private hospital, there's a free wing. So this patient was admitted there. We did X-rays were not an issue. The digital X-rays was done. And this is what we saw. Markedly elevated right hemidiaphragm, and not only that, there was even a fluid level. So that supported the clinical diagnosis of a liver abscess in the subdiaphragmatic region. So refer to the patients. Now we are living in a more sophisticated era. Surgeons told we can't take the patient over without ultrasound scan. So now what to do? There was no radiologist in the ward in that hospital, but our junior doctors were very dynamic. They knew I was getting a bit restless when I saw this X-ray. Just a thin film of tissue, sort of separating this abscess from the pleural space. I didn't know when it was going to rupture. It was like a ticking time bomb. So they were very active. Somehow they got down a radiologist, did the scan, confirmed the clinical diagnosis of a liver abscess. After that, the surgeons did a wonderful job and the patient survived. A lot of credit must go to the junior doctors for their pursuance in getting a scan done very quickly. So even as a veteran, I'm still learning. So the lesson I want to get across is listen carefully to the patient. However vague the symptoms may be, however well the patient may appear to be, if the patient says, I'm not well, then the patient is not well. There's something wrong. And it is left for us to discover what it is and treat that appropriately. Now this was just 1 year after I had retired, working in the private sector again. This young girl walked into the consultation room with her mother with a complaint of acute pain, just of 1 day's duration, which was felt in the right iliac fossa. Was wondering whether this patient had acute appendicitis, but there was no fever, vomiting, or anorexia. They also entertained the possibility of a twisted ovarian cyst or a ruptured ectopic. Even though she was unmarried, there's nothing to prevent an unmarried person from getting pregnant. And the way she was walking in, the gut feeling I had was that she had a ruptured ectopic. And in fact, I was wondering why she was coming to see me when she should have gone and consulted a gynecologist. But the general condition was perfect. Blood pressure was 120/70, good pulse volume. To examine the patient on the patient's abdomen, I got the patient to lie down on the bed. And the moment she lay down on that bed, I noticed a grimace in her face. Then I asked her, did you feel a pain? If so, where did you feel the pain? And she told she felt a pain in the right shoulder tip. Now that observation strengthened the suspected diagnosis of a hemoperitoneum from a ruptured ectopic. It was a small rupture, very little blood which was collected in the pelvic cavity, but when the patient assumed the supine position, the blood tracked superiorly, irritated the diaphragm, and that's how she got the right shoulder tip pain. And had I not observed the grimace in the patient's face, I would have missed the diagnosis. Now, for further evidence of an ectopic, I needed to establish that she had a period of amenorrhea. Now, I couldn't ask that with the mother there. She was an unmarried girl, and the mother was also a little bit nosy, wondering what was happening. So I had to send the mother and the channel aide out of the room, and with confidential interrogation, she admitted to having a boyfriend, of which this affair the parents are not aware. But then I asked her, did you miss any periods? She told no. I asked her again, did you miss a period? Did you have your periods? She said, I had it. Every month I had it. So no POA. Then I asked her accurately what was the last regular menstrual period, and then she admitted to having had sex, unprotected sex, which had coincided with the date of ovulation. So she had got pregnant, the ectopic had ruptured before there was time for the POA to express itself. So that missing essential clue clinched the diagnosis of a ruptured ectopic pregnancy. And now I face the real dilemma of managing the patient from that point onwards. The patient had to see a gynecologist, needed a scan and urgent surgery, way beyond my control. So I had this dilemma of how I was going to conceal the truth from the mother, but at the same time not delay these life-saving interventions. So with some diplomacy, tact, and being very assertive, we managed to save not only this young girl's life, but also the entangled social and family issues that we need to grapple with onto this clandestine affair and the pregnancy in an unmarried girl from a very conservative family. So ladies and gentlemen, the diagnosis of an acute abdomen is very challenging. The surgical emergencies you need to keep in mind in this context is peritonitis, which may be due to a ruptured duodenal, perforated duodenal ulcer, which was very common when we were juniors, but because there were no proton pump inhibitors or H2 receptor blockers, but I don't think you see it all that often now. The other one is intestinal obstruction and hemoperitoneum that can be due to a ruptured spleen or a ruptured ectopic pregnancy. So 3 surgical emergencies of an acute abdomen. Please keep in mind, wherever you are working, whatever department you are working, all this can come under your care. Peritonitis from perforated abscess, from viscous intestinal obstruction, and hemoperitoneum. Now, the diagnosis of an acute abdomen is a clinical diagnosis. All what you need to do is to look at the patient's tongue, feel the pulse, and examine the abdomen. The standard way, going through these standard steps of the prayer we studied, we sort of memorized when we were medical students of inspection, palpation, percussion, and auscultation. If the tongue is dry and furred, it's likely the patient has peritonitis. If it is pale, the chances are there's internal bleeding. Rapid low volume pulse is internal bleeding. And when you examine the abdomen, follow these steps carefully. It's not enough at our level to say that the abdomen is just distended on inspection. Try to appreciate the subtle differences of this distension that will enable you to discern between the distension from intestinal obstruction and the distension from ascites. And palpate the abdomen. It will be tender. It will be tender and guarding if it is acute abdomen, but don't stop there. You should be able to appreciate the subtleness of softness, firmness, and board-like rigidity. So a tender abdomen which is soft is often due to a hemoperitoneum. If it is tender and firm or rigid, it's from peritonitis, from a ruptured appendix. If it is tender at board-like rigidity, that is due to a perforated duodenal ulcer. Percussion, shift in dullness will tell you whether there's fluid, and never ever forget to percuss over the liver. Obliterated liver dullness is a very useful clinical sign of bowel perforation. An auscultation will reveal a silent abdomen in peritonitis and paralytic ileus, and the enhanced bowel sounds, distended abdomen, is mechanical obstruction. So that's a distended abdomen. You see the generalized distension, but try to observe that fullness, which is more in the flanks. So this was due to ascites and not intestinal obstruction. So the clinical art of diagnosing an acute abdomen essentially revolves around these basic techniques of applied intelligently and appropriately, and you'll be able to pinpoint the diagnosis in under 10 minutes with almost 100% certainty. And why am I harping on this so much? Because such an approach will enable you, it serves really to avoid delays in life-saving interventions. Now these are the crystals I saw, and all of us would have seen in the chemistry lab in our school days. This is copper sulfate. Many decades later, I came across this teenage girl working as a junior when I was working as a junior doctor at the General Hospital Colombo, which is now called the National Hospital Sri Lanka, and she was admitted after the ingestion of copper sulfate with this complaints of abdominal pain, vomiting, but everything was normal otherwise. 10 hours later, she took a bad turn. She became acutely ill, sudden onset of a sallow complexion, profuse sweating, and she started to pass black-colored urine. It was profuse. All the urine from the start to the end was black in color. Now we go to the botany lab in school days. I love this plant, Acalypha indica, which is also called Cupamania in Sinhala. In 1991, working at Anuradhapura, this family, the father who was a farmer, along with his 2 teenage sons, was admitted to our medical unit. Soon after lunch, feeling unwell, abdominal pain, vomiting and feeling unwell. All of them had eaten Cupamania as a mellow. But the clinical condition was stable at the time of admission. But towards the evening, all these patients also started to pass black-colored urine. 2 years later, I was transferred to Abissavel and came across this young adult male. During the morning ward round, he was in pain, great discomfort, hardly able to talk, no detailed history was available, but he had severe burning sensation, which was mainly in the retrosternal region. That's the patient propped up, and I noticed this black discoloration around his mouth. And the next day, he became acutely ill and started to pass black-colored urine. That's a urine which was collected into an empty saline bottle. I'm very sorry about the quality of this picture, which is quite old. Anyway, not as old as the person who is making this presentation. Putting all these facts together, the black urine, burning sensation in the chest, circumoral discoloration, which I attributed to burn marks, being a rubber tapper, easy access to acetic acid, all this was attributed to acetic acid poisoning. Then very recently, just a couple of years ago at Malabe, this patient with dengue fever on day 3 suddenly started to pass black-colored urine. He was under the care of another consultant colleague of mine, and I was informed because of my interest in dengue. And this HO sounded very worried. I told her, don't panic. Keep all the urine the patient is passing for me to see. And I was on my way to the hospital, and this is what I saw. Having treated over 5,000 patients with dengue, never ever had I seen a patient with dengue fever passing urine of this color. It was pitch black, uniformly black. So all these patients who passed black urine was attributed to hemoglobinuria resulting from acute intravascular hemolysis. So despite had quite a wide array of unrelated causes, copper sulfate, Acalypha indica, acetic acid, and dengue fever, but all had black urine, and all these patients, it was concluded as being due to hemoglobinuria resulting from acute intravascular hemolysis. Despite this etiological diversity, all these patients followed the same emergency management pathway of forced diuresis, which was early and aggressive. The only patient we investigated in depth was this patient who had dengue fever, and you can see how the hemoglobin has dropped from 14 to 7.6, markedly elevated LDH, raised serum bilirubin, and the fact that there was hemoglobinuria was also confirmed by photospectrometry. And because of the propensity of hemoglobin to give rise to acute kidney injury, the management priority in this patient was forced diuresis. So we gave large quantities of fluid to this patient, 4 to 4.8 liters over a 24-hour period. This went on for about 6 days, but the patient eventually survived. And you can see the change in the color of the urine from black before diuresis to what it was during diuresis. And this is the color of the urine at the time of discharge, and very importantly, he didn't develop acute kidney injury, which was effectively prevented by forced diuresis. And this was published in the American Journal of Tropical Medicine and Hygiene in February last year. So acute intravascular hemolysis is a clinical diagnosis. Any patient passing black urine in the appropriate clinical setting of falciparum malaria, G6PD deficiency, or exposure to these toxins and viral infections, including dengue infection, should be inferred as being due to acute intravascular hemolysis, hemoglobinuria. And you need to suspect, you can suspect patients to have G6PD deficiency from the residence, as well as consanguinity, history of consanguinity, and even the accent. If you're sharp enough, you're listening to the way the patient talks, you'll know that patient is from Nochiagama or Maradan Kadavala, and then the exposure to the incriminating agent. So it is essential to diagnose this very early. Patient passes black urine. The management priority is to prevent AKI by promoting diuresis. For this to be effective, it has to be started early, aggressively, in dynamic fashion. Now, there are 82 patients in my career who had black urine, all due to acute intravascular hemolysis, and 79 were over a 1-year period in Anuradhapura, and none of them all survived, and none of them needed any form of dialysis. The magic treatment was the early bedside diagnosis of looking at the urine and treating with saline and furosemide. Absolutely cheap form of treatment. Now we talk of a urine of a different color, orange urine. Doing the ward round, coming to this patient, this is what I saw. Then I looked at the patient's face, and this is what I saw. So there was orange stained buccal mucosa, orange colored urine. Then I turned to the register and asked, what is this patient with tuberculosis doing in this ward when he should be treated at the chest hospital, Valisara? And they told me, yes, this patient was at Valisara, admitted the previous night because of vomiting and feeling a little unwell. So this was the rifampicin which caused all these discolorations. Coming on to dengue, for patient with dengue infection, complaints of abdominal pain and tenderness in the febrile phase, it predicts the transition to DHF. But we have come across some patients with dengue infection who had severe abdominal pain and tenderness which was resistant to analgesics, which responded to fluid boluses. This was one such patient where the pain persisted despite an escalation of analgesia, responded to crystalloids, and we had to give large quantities of fluid without no fluid overload. This is another patient, pain subsided from 6 or a score of 6 to 3. Another patient, again, pain subsided with fluid boluses, ended up by receiving 6.5 liters of fluid, far in excess of the guideline quota of 4.6 liters. And that's a patient, no evidence of fluid overload. So based on this experience, I'm tempted to postulate that certain strains of dengue virus seems to cause, in some intriguing way, a derangement in the microcirculation, which causes visceral ischemia manifesting as refractory abdominal pain. And so if you come across a patient with this refractory abdominal pain, the abdomen is tender but soft without any guarding, with stable systemic parameters of hemodynamic parameters of the target values for fluid therapy, give the patient excess fluid. Now this I'd like to call permissible fluid overload, where we exceed the fluid quota without adverse outcomes, bearing in mind that fluid overload is far safer than shock. Pruritus and bradycardia is a diagnostic hallmark of convalescent, but we have patients who have developed these features in the critical phase while leaking plasma. That's a patient, and this is another patient. And now steroids are generally contraindicated in dengue infection, but this was a patient with DHF who had a very smooth convalescent phase, but became hemodynamically stable, developed abdominal pain in the convalescence, and the white count started dropping in the convalescent phase when it should have been rising. So we suspected hemophagocytic lymphocytosis for this patient. So that's a rare complication of dengue which has to be detected early, treated early, and it is with methylprednisolone. You suspect it if you find all the cell lines dropping during the phase of convalescence. This was a dengue patient on day 1 who was drowsy with disconjugate eye movements. We suspected dengue encephalitis, confirmed by EEG, it was compatible. Fever dropped within 2 to 3 days, and the patient on discharge managed with dengue encephalitis. So the diagnostic clue is the cerebral obdentation from day 1. Now this was a patient in the Colombo South Teaching Hospital where the patient was transferred. Thanks. Can I stop? Okay. So I just wrote, this was a patient who was transferred for a CT scan with a suspected SOL. I found the patient to have neck stiffness, hyperreflexia, and icterus. So suspected clinically cerebral malaria, treated on those lines, and the patient recovered without a lumbar puncture or CT scanning. So diagnostic hallmark in cerebral malaria is unrousable coma, icterus, and fever, and these days you give intravenous artesunate. This was a patient who was unconscious, febrile illness, unconscious. They were suspected bacterial meningitis, getting ready to do a lumbar puncture. I thought the patient didn't have the meningitis look, was wondering whether it was neuroleptic malignant syndrome, but there was no history of all that. Looking at the temperature chart, suspected this patient to have typhoid. This was in 2000 when such typhus was unheard of, and started examining the patient again for ESCA, discovered it. Patient was treated with chloramphenicol, no lumbar puncture, dramatic recovery. That's a scar from another patient, which is quite common. This was at Malawi. One last patient. This was 30 years ago at the General Hospital Anuradhapura. She was unconscious. She looks awake, but she is unconscious. This patient had a vacant expression, which was the diagnostic clue for Japanese encephalitis. So to end this patient, then, the art of clinical medicine. General physician comes across this very broad spectrum of clinical problems which are fascinating. This is just a mere glimpse of all that. You need to have a holistic approach, good clinical acumen, and all these clinical skills you learned as medical students should be developed, cultivated, and refined to be able to pick up pertinent clues in the history and the exam that will enable you to zoom on the problem. And clinicians generally must get connected with the patient, the clinical touch, and this is the sort of connection, mental, psychological, give all that support, transcending all barriers. And a simple technique to do this is to hold the patient's right hand with your right hand, feel the pulse, you are getting connected, and at the same time, it will take you, this simple technique will take you to a different dimension of being able to cognize the patient's overall condition as well. So assess the patient totally, not treat just the systems, you are treating the patient as a whole. So general physicians are pathologists. specific therapy for identified prioritized problems, which is given early and empirically. Individualized care plan is certainly important based on evidence, but it has to be applied with empathy and common sense to benefit the patient. Thank you very much. I'm sorry I took a couple of extra minutes.
Thank you very much, sir, for that excellent lecture. I think you took us through a gamut of cases, and I'm sure the trainees here and all the young doctors and all of us have learned a lot from you, which was the intention of having this special segment in our sessions. Thank you very much, and now I invite Professor Namal Vijayasinghe to present the Certificate of Appreciation.